Female body and some gynecological terms, those are important for us to know. The first thing is the normal hormonal pattern. As we all know, female body goes through a change in hormonal patterns every month, right? Every month this cycle repeats itself every 28 to 30 days. The first phase we get through is proliferative phase, in which the estrogen increases. Next is ovulation, where estrogen peaks 48 hours before ovulation, and LH surge that occurs 24 to 36 hours before ovulation. Next phase we get into is luteal phase, in which progesterone is a very high and estrogen is also in a higher level, whereas LH and FSH both decreases. In the menstrual phase, or we else known as bleeding phase, estrogen and progesterone both decreases, whereas LH and FSH in okay. The next, the condition that occurs due to abnormal hormone secretion. This is prolactinoma, that occurs due to increased prolactin secretion, which inhibits hypothalamus, that decreases GnRH, which further decreases LH and FSH, which further gives us symptoms like amenorrhea, infertility, and galactorrhea in a female. The next condition we'll be talking about is primary ovarian insufficiency. In this primary ovarian insufficiency, there's loss of oocytes even before 40 years of age. In this, we get a test done for serum follicular stimulating hormone, two tests 1 month apart, and if both gives us a greater value than the threshold 30 to 40 milli international units per ml, we confirm it to be primary ovarian insufficiency and not a physiological cessation of ovulation. The next thing is anti-Mullerian hormone. Now, what is the role of anti-Mullerian hormone in this primary ovarian insufficiency? This anti-Mullerian hormone, this hormone is used for follicular development and oocyte maturation in a female. So normally the level of AMH is 2 to 6.8 nanograms per milliliter. Reserve, when this value is less than equal to 1, it means it has poor ovarian reserve. If it's more than 10, then it's due to PCOD or hyperstimulation surge syndromes. Checking the ovarian reserve of a female, there are some tests. The tests are, the best one is AMH. As I have already told, it signifies the follicular development and oocyte maturation. So the first one is AMH, the second one is AFC, antral follicular count, the third is FSH and LH, the next one is inhibin B level, and the last one is serum estradiol values. This part of gynecology, that is D Lancey's level of supports, but there's many prolapse. So for that we have D Lancey's level of support. We get a various questions on this. These are genital organs and their support, so there are levels for this. The levels are, the first one is, where these are the supports and these are the consequences if the support doesn't work. This is the second level and third level. The first one is cardinal ligament, that is McEnroth's ligament or uterosacral ligament. These are the support structures. If not able to support us, consequence will be uterine prolapse, uterine descent, vault descent, या फिर enterocoel. The next is lateral attachments. The consequences are cystocele and rectocele. Whereas urogenital diaphragm is also a support, but if it doesn't help, the consequences are urethrocele, gaping introitus, and deficient perineum. So these are the D Lance's level of support or genital organs. Next we come to adenomyosis. Adenomyosis is the condition. So The clinical features by which a female comes is menorrhagia, dysmenorrhea, dyspareunia, and pelvic discomfort. On examination, a gynecologist will found a gross symmetrical enlargement of her uterus. For the management of adenomyosis in young females, we will be firstly getting into medical management, giving NSAIDs, hormonal medications will be giving. Mirena IUCD we can use, local excision we can do for adenomyosis. Next comes the older females who have adenomyosis. In this, we do dilatation and curettage for menorrhagia. Dilatation and curettage, this is also a diagnostic test. When it comes to be normal, we can do hysterectomy with or without salpingo-oophorectomy. Hysterectomy with or without salpingo-oophorectomy we can also perform. The next thing we will be understanding is the condition of PCOS, polycystic ovarian syndrome. This has a beautiful criteria of Rotterdam criteria, in which we have three criterias. So for being a PCOS patient, you should have two out of these three criterias. The first one is irregular menstrual cycle. The second is hyperandrogenism, that is hirsutism or acne. Conditions like hirsutism and acne. Ultrasound findings like enlarged ovary with peripheral multiple follicles, and this kind of arrangement is called a necklace appearance. Okay. Next, where we have studied about D. Lance's level of support, we will also be studying about uterovaginal prolapse. In this uterovaginal prolapse, we have four kinds of or four levels in this. The first one is descent of cervix into vagina. The second level is where descent of cervix is up to the introitus. The third is descent of cervix up to outside the and introitus. And the last one is procedentia, in which all of the uterus is outside of the introitus. This is uterovaginal prolapse. For the pelvic organ prolapse, we have a quantification system, that is pelvic organ prolapse quantification system. This is a very complex kind of system, and in this the hymen is put as a fixed point. None of the question has been asked on this, but this is a term that we should be knowing. The next thing is a patient came with tenderness, mild erythema of breast. Imaging, on imaging we get a hypoechoic and irregular mass. On biopsy we have cystic spaces surrounded by neutrophils. There are cystic spaces which are surrounded by neutrophils. Cystic neutrophilic granulomatous mastitis, which is caused by Corynebacterium cropenseti. So this is all about cystic neutrophilic granulomatous mastitis. The next two small conditions that we should be talking about is Turner syndrome. First of all, chromosomal abnormality of 45XO we have. Okay, there are many characteristic features of Turner syndrome, as you already know about it. The thing we should be getting a focus on is most common. This is the most common sexual chromosomal abnormality in a female, and this is a common cause of primary amenorrhea. In HPV infections, we have symptoms like dysuria, pelvic pain, abnormal vaginal discharge, and the pap smear looks like large hyperchromatic nuclei with perinuclear halo, and these cells are known as koilocytes on the pap smear. A condition called lichen sclerosis has been asked sometimes in the exams, medical entrances. This is a non-neoplastic inflammatory dermatosis. This occurs in postmenopausal females. Symptoms of this condition are there's itching, excoriation, vulval skin thickening in this, and this is all due to lichenification. Appearance It appears as white atrophic papules that may even coalesce into the plaques. Biopsy is needed to exclude the malignancy in this condition. The next small topic is myomatous polyp. Myomatous polyp is a type of a fibroid polyp, a type of benign tumor that originates from the smooth muscle cells of uterus called leiomyomas. On examination, there's a globular structure that is attached by a stalk into the uterine cavity. The symptoms that occurs in this are menorrhagia, pelvic pain, and pressure. The next thing is genital TB. How this appears, how the patient comes to us. It could be, first of all, I can say 10 to 15% are even asymptomatic. Some are symptomatic with symptoms like secondary infertility, abdominal pain, vaginal discharge. Laparoscopically, when we see multiple granulomatous foci will be seen, that is tuberculous lesions. So, almost this genital TB is almost always secondary to a primary focus somewhere, and most commonly it's lungs, right? Fallopian tube is the most common site to get affected, and in investigation of choice, we do endometrial biopsy. Diagnostic laparoscopy is widely used to establish diagnosis of either genital TB or abdominal pelvic TB.